Okay, awesome. Hello, everyone. Welcome to our hand GM meeting 5. Today is February. Woo! Right off the bat, okay, a couple of announcements, I guess. Next week, we have our healthcare panel, and it's going to take place in our regular meeting time, so hooray. And then the following week, we have one of our club advisors, Dr. Darlene Mayo. She's going to come speak to us. And then for our icebreaker today, we have a form or two forms if you want for you guys to fill out. And one of them would be a mid-quarter feedback form that Ashley's going to send in the chat. And then the other form would be for if you would like to join the PR committee. We're allowing the option of both staying in your current committee and helping out in PR, or you can switch to PR if you want. But regardless, the form is in the chat right now, and it will take 6 minutes for you guys to fill it out. And Nitin is now going to be our DJ. Is it gonna stop my sharing? I'm gonna stop recording. Oh.
Okay, so today we will be talking about different treatments to neurodegenerative diseases. And so we're going to go through a case study with sort of like an intro breakout room session. Then we're going to go through 5 different treatment methods, and then we're going to come back to case study at the end with more breakout rooms. Next slide, please. All right, so this one's just a basic, more vague example to try to get you all start thinking. And we're going to send you into breakout rooms with about 5-6 people so that you can sort of brainstorm the different treatment options we do have at our disposal. And so I'm just going to read this out loud, and I'll also put it into the chat so that you guys can access it when you're in breakout rooms. So you're a physician at Ronald Reagan Hospital. A 67-year-old woman comes in with severe headaches, action tremors, occasional mood shifts, vision and spatial issues, and pain in her left ankle. And we're asking you to try to figure out how you would go about diagnosing her and treating her disease. Next slide. All right, so Tiffany, if you could set up breakout rooms, please.
Sweet, they should be open. Also, if you're not comfortable being recorded, let us know. We can crop out your speaking part. Yes. Kovir, are you leading this section or am I talking?
Up to you. I was just gonna go through each of the breakout rooms and just have everyone present real quick.
Yeah, I was thinking that too. That'll be great.
All right, so why don't we start with breakout room number 1?
Yeah, that was us. So our method was that we would, when they came in presenting with these things, we do a neurological test, like the standard neurological test that they do when you go in to like see if there's any like abnormalities in their neurological functioning, like if their eye movements are slow or something. And that would like give us an indication that there's probably like a deeper neurological problem going on, for which we then order some scans for them. I think the ones that were mentioned were a PET scan, a MRI, and then an MRS. So we do those scans, and then we'd look for the like markings. There's certain markers on the scans that can imply a genetic disease. A neurodegenerative disease. And then if we saw that, we may probably take some like blood and do some genetic tests because there are genetic markers as well. So we do that. And it was mentioned about like enzymatic activity to look into that to see if there's abnormalities there and to test like levels of chemicals in their brains like dopamine, because those are also symptoms of neurodegenerative diseases. and to like compile all these things to get like a broader view of if they have neurodegenerative disease and what the neurodegenerative disease could be. And then we were thinking for treatments, there are some drugs that are available that can like increase production of different like hormones in the body, like dopamine. So we were thinking to try them out if we weren't certain, to like try out certain ones meant specifically for like Parkinson's or Alzheimer's and see if there's like drastic improvements or like problems. And then we could like narrow it down from there if we were still uncertain. And then we'd also be treating their disease on the meanwhile.
Yeah, those are some really, really good ideas. That was like a really detailed response, actually. So I'm really glad you guys got such a great discussion. Yeah, that pretty much covers most of the stuff we were looking for. So I think rather than going group by group, maybe we can just have people add on. So if anyone else has anything to add to the discussion, definitely go for it right now.
I think the only thing I'd have to add is like we had like almost the exact same response as Shruti, but obviously I think this goes without saying, just asking how long the symptoms have been going on before and then getting down the family history. So yeah, not that much to add. Shruti basically covered all of it.
Yeah, nice job, guys. That was a solid response. Anyone else? Seems like you guys either have been listening very, very attentively in all the presentations, or you're just really good at searching this stuff up. But either way, nice job. Okay, so nice job, group one and Sasha. And I'm sure all of you guys did a really good job too. But anyway, we will move on now. And then for the last breakout room session, I think we can go through all the groups just to get a little more representation.
Sounds great.
Okay, so one of the treatment options that can be used to treat patients with neurological disorders or disease is physical therapy. So the brain and spinal cord control movement and sensations. So injuries to these areas can cause death of the cells that control certain movements and sensations, which in turn results in people losing function in certain body parts. And without neurological physical therapy following a neurological condition, patients may lose many functions and not be able to perform certain activities. And decreased physical activity leads to many other health problems such as diabetes, heart problems, lung problems, decreased independence, and an overall poor quality of life. And physical therapy doesn't cure the disease or disorder, but it can treat movement problems that often occur as a result of neurological disorder or disease and improve the individual's overall quality of life. And if the individual hasn't experienced any loss of function related symptoms yet, physical therapy can also minimize the symptoms when they do occur or prevent the onset of symptoms completely. Common neurological disorders and diseases that are treated using physical therapy include stroke, multiple sclerosis, and spinal cord injury. Individuals are usually provided with a specialized one-on-one treatment that tends to their specific needs, such as focus on improving motor control, posture realignment, or cardiovascular endurance. And following the neurological disorder or disease, there's a certain amount of time when the cells that are not injured in the brain and spinal cord can learn to control the missing functions. And physical therapists have extensive knowledge about human movement, and they can teach patients how to move correctly again. So this assistance can help patients regain some or even most of the functions they lost because of the injury, and most of the patients can learn to live their lives independently again. And this in turn makes them happier with their lives and contributes to their overall quality of life. Next slide, please.
So oral drugs can be prescribed to reduce or eliminate side effects of short-term or chronic neurological conditions. There are several types of oral drugs with different usages. So first off, there's anti-seizure medications, which are used to help stop or control seizures, as well as relieve pain that comes with nerve damage. Second is blood thinners like aspirin, which go a long way in preventing a stroke. Then there's corticosteroids and disease-modifying drugs that are prescribed to reduce the symptoms of multiple sclerosis. Fourth, there's dopaminergic medications that are prescribed for patients with Parkinson's disease to help produce dopamine and reduce symptoms such as muscle rigidity, slow body movement, poor coordination, and tremors. Next are clot busting drugs that like their name implies, dissolves clots so that blood can flow. Next is immunotherapies, which help reduce the inflammatory response that triggers symptoms for disorders such as GBS. And finally, there's antidepressants, which reduce sleep problems, relieves pain, and improves mood for patients with neurological disorders. One thing to keep in mind is that drug tolerance can develop over time, causing the drug to lose its effectiveness. Next slide, please.
All right, so the next treatment method we are going to discuss is gene therapy. So with the modern medical approaches we just discussed, the treatment of neurological disorders remains difficult due to the complexity of the central nervous system, specifically in the blood-brain barrier, because it makes it difficult to transport drugs directly to the brain or prevent side effects. So gene selective approaches actually work to directly correct the disease-causing mutations by manipulating RNA expression in order to restore gene function. So it's essentially a correction of the DNA defect. It can introduce new genetic material into the cells, replace or fix mutant genes. It can induce production of a therapeutic protein, or it can generally aid the immune system in recognizing diseased cells. One approach is vector-based gene therapy, through which viral vectors or capsids are genetically engineered to encode a functional protein or a regulatory RNA. You're essentially inserting new, fully functional genes directly into the nucleus of a patient's cells to replace or silence the disease-causing gene. And you do this by injecting into the CSF directly or target tissues. Another gene selective therapy is in vivo genetic genome editing, such as the gene editing method of CRISPR nucleases, which most of you might have heard in biology classes, but they're designed to recognize and cut the target DNA sequences. And these cause double-stranded breaks, which are then repaired by the cell's DNA repair mechanisms and in the presence of a donor DNA template that the nucleases provide. And they're delivered to target cells through the vector system, like a plasmid, a virus, or a nanoparticle. And then a last method is the process of RNA splicing, where wanted or unwanted exons are included or excluded, depending on the function of the gene itself, through the manipulation of small molecules which target splice sites. And overall, gene therapy is a pretty tedious process because biomarkers need to be discovered that properly correlate with disease progression in order for these methods to take place. And also there are various risks as of now, such as unwanted immune system reactions or targeting the wrong cells. And these continue to be uncovered with ongoing research. Next slide, please. So this is a figure of the different mechanisms of gene-specific therapies we just spoke about. Letter A shows the function of ASOs, which are small molecules, and these target mRNA, and they lead to the degradation of the target mRNA, like of the disease-causing gene. Letter B shows an ASO, while letter C shows a different small molecule targeting a splice site of an exon to mediate exon exclusion or inclusion, to express a different amino acid of a target protein that is more functional. Moving along, D is demonstrating the degradation of the target mRNA through which the binding of a complementary siRNA leads to the degradation of the target mRNA. And then lastly, E and F depict viral gene transfer through which exogenous DNA codes for an mRNA of choice, or it encodes an mRNA which then mediates the degradation of target mRNA. While these methods continue to be tested in preclinical and clinical trials, these therapies can directly target a disease gene, and that makes it really promising for the future of the treatment of neurological disorders. So yeah, next slide, please.
Okay, now moving on to surgical methods. So the thing about surgical methods is this is usually like the last approach that's taken. So it's after things like physical therapy and oral medication hasn't been working for a while. So then surgeons will move towards surgical methods. So one surgical method for treating neurological disorders is multiple subungual transection. And that's basically used to treat epilepsy seizures. And it helps to stop these seizures by cutting the nerve fibers in the outer layers of the brain, so in the layers of the brain that are causing the seizures, and sparing the vital functions concentrated in the deeper layers of brain tissue. So it only cuts a small portion where vital functions won't be impacted. And the more common type of surgery, especially for epilepsy, is resective surgery. It's a removal of a small portion of the brain, so kind of similar to the one I just talked about. But this one is more effective when seizures always occur in a single location in the brain. That way you can just take out a small portion without harming other parts of the brain, and the person's cognitive functions are still intact. And the surgeon basically cuts out brain tissues in the area of the brain where seizures occur, usually the site of a tumor, a brain injury, or malformation.
Okay. Sorry, one more thing on that last slide. Okay, so just to go over corpus callosotomy, I hope I am saying that correctly. Anyway, so corpus callosotomies are actually a little bit different from the other types of surgeries we have listed here, in the sense that they don't stop seizures. Their purpose has never actually been to stop seizures. The purpose is to cut the nerve fibers at the corpus callosum, and that's the part that connects the two hemispheres of the brain. And that's to ensure that seizures don't spread from one side of the brain to the other. And so in certain patients, this can really help with reducing the severity of the seizures. And this procedure is most commonly used in children with severe seizures that encompass both sides of their brain. And so it is kind of a more extreme procedure that, again, as Neha was saying, it's taken as more of like a last measure after other methods have been tried.
And now deep brain stimulation, which I personally think is like my favorite in terms of treatment. It's basically a medical device called a neurostimulator, which is placed on a person's chest. And then there's electrodes that are implanted into the brain that will target specific areas of the brain. And the stimulator will then send electrical impulses, which will then block the faulty nerve signals that are causing tremors, rigidity, and other symptoms. So it's mostly used to treat Parkinson's, dystonia, Tourette's, epilepsy, and even OCD. And again, like I talked about, it's mostly used for reducing uncontrollable shaking movements. And usually a person who is a good candidate for deep brain stimulation is someone under 70 years old. And kind of like we talked about in the other like surgical methods, it's when they're having on and off medication states. So the medication will be working, but then it'll wear off and it won't be working anymore. So they'll have like uncontrollable tremors that they won't be able, that aren't being treated with the medication. So they turn to deep brain stimulation. And something to note about deep brain stimulation is that they want patients who have little to no cognitive dysfunction. So that's why sometimes people with neurological disorders aren't able to be a candidate for deep brain stimulation, because with the neurological disorders comes cognitive dysfunction. So that's why it's important that if they want to be a candidate for this, that their doctors would have to like recommend them before their disease progresses. And then next slide. And then this is just a diagram of what it kind of looks like. So like the neurostimulator I talked about, that's usually placed around the chest. And then there's electrodes that are implanted into the brain. And then there's like these pieces of lead that are connected with these wires connected to the neurostimulator, which then send signals to the electrodes in the brain.
Okay, so now we're going to be going through the second part of our case study. And so again, I'll read this out loud and then I'll put it in the chat at the end. All right, so Dr. Tiffany Chen is working at the UCSF Medical Center, and she's been treating a man named Erlich Sakari for 3 months. He is 46 years old and has been taking levodopa for 3 years, 7 months, and 13 days. However, he has been experiencing dyskinesia as of late, as well as tremors, rigidity, and slowness in movement. What should Dr. Chen do? What are some factors she should consider in choosing a treatment? And so you guys did a really good job the first time around. This time we want you to sort of take a bigger focus on the treatment and trying to choose one or maybe multiple options.
Oh, I accidentally clicked that and it scared me. That's okay. We're back. Let's see. Okay, I think we're waiting on 2 more rooms. Okay, that should be everybody. Yes, Sasha.
But what happened?
Oh, sorry. I just thought you were unmuted and thought you were gonna.
Oh no, I was like unmuted when I came back. Sorry.
But sure, I can take the discussion. We can start with group 5. What are the steps you guys would take?
I just kind of thought like since that patient has been taking it for more than 3 years, they most likely develop like a tolerance to the levodopa drug. So I guess like some factors she should, or I guess you should be considering in choosing a treatment is that either like increasing the dosage of the drug, or another alternative would be changing prescription to like another like dopamine agonist drug, or some sort of like maybe like a serotonin inhibitor, but something that just like promotes the influx of like dopamine into the brain, because that helps with Parkinson's. And then like if that doesn't work, then transitioning to like a more invasive treatment. But I feel like that would be like last ditch effort.
Perfect. Really thorough response. Group 5 and Max, good job. Moving on to group 4.
Yeah, so we said we'd probably, because he's been using the drug and it's probably not working as well, that we'd try DBS because he's still pretty young. He doesn't have any neurological actually. He's young, and he may have Parkinson's. So we also said physical therapy because that's also helpful. Maybe speech therapy because that's also helpful. And yeah, I feel like we're missing something, but that was the overall thing. So Dr. Chen, please take advice.
Awesome. Well, thank you, group 4 and Daniel. Group 3, if you guys have a rep that would like to speak out.
Sure, I can go. So what we talked about is we didn't, as for the intolerance, we actually thought that lowering the dose but increasing the frequency of levodopa would help more, because we actually read up that keeping the dopamine level more consistent for a greater amount of time would help reduce any symptoms of like dyskinesia. And we also recommended using physical therapy in tandem. There's also another pharmaceutical drug called amantadine. It helps increase, the production of dopamine, and that could also work with the levodopa, since it's very likely that the individual is more resistant to levodopa. And then after that, we would go to something more extreme like DBS if those still weren't effective.
Awesome, thank you, group 3. Sasha? Group 2?
Our group had pretty similar as the other groups. Like we also mentioned that we would recommend physical therapy since many of the symptoms that he's experiencing, like they're physical symptoms. And then one thing we added was like maybe the levodopa not being so useful as before was because the disease progressed rather than like developing resistance. So that was what our group discussed.
Awesome, thank you, Austin. And last but not least, we have group 1.
Yeah, we did We decided on most of the same things other people said. We agreed that because he's experiencing these symptoms, he probably is developing resistance to his medication. So if he isn't at the maximum amount of medication we can prescribe, we were thinking to up his dosage a bit to see how he reacts to that, and simultaneously put him to like physical therapy or some other form of exercise that would be able to help him improve his muscular coordination so that he isn't experiencing these tremors just as much. And then if these in tandem don't seem to be working very well for him and he's still like experiencing the same symptoms and they're getting worse, we were thinking about deep brain stimulation as our next step there, because it's much more minimally invasive than like actual surgical procedures. And because levodopa is really the only Parkinson's drug in the market, we didn't want to like risk it with a different drug. So we were thinking deep brain stimulation would provide a nice medium there where it's minimally invasive and there's like less room for risks. And then we can also, if his symptoms continued after the deep brain stimulation, then we were thinking of like combining it with a little bit of levodopa to see if there is any improvement with that.
Awesome, thanks, Shruti. And group one, so it seems like majority of the groups recommended a combination of physical therapy with either a change in the dosage of levodopa or a change in medication. And then a lot of groups mentioned if the symptoms continue or worsen, to recommend DBS as, I guess, the extreme option. Anything else I missed or any comments?
Just one quick one that Sasha brought up, just like is dyskinesia caused by levodopa? And so yeah, like dyskinesia is like a side effect. So if you use it for a really long time, you use levodopa for a really long time, you could get it. So sometimes weaning someone off a drug and then maybe putting them back on it maybe might help in terms of a treatment plan, just depending on like how long they've had it and then if they've had other drugs in their system as well.
Awesome. Okay, well, there we go. And I believe this concludes our presentation for today. Thank you again to Education and everyone for contributing. We'll send out the forms again in Slack, and I want to emphasize that we're open to feedback. So we'll be looking through the form and trying to implement different changes. And also, if you want to help out in PR, just fill out the form we're going to be sending out. Pauline would really appreciate your help. And yeah, look forward to our nice panel next week and the following week. But yeah, take care, guys. Good luck on midterms.